Hello and welcome to today's webinar hosted by the Follicular Lymphoma Foundation. We're absolutely delighted to see such a brilliant turnout, so thank you for joining us today. We've hosted a number of webinars before as part of an ongoing series, so if you enjoyed today's session, then there's more to come. We'll pop a link in the chat shortly so you can explore past and future events. And then just a few quick housekeeping notes before we begin. Today's session is being recorded and we'll upload the final video on our website. Only the speakers will be visible in the recording, so rest assured participant comments will not appear. Feel free to ask questions at any time throughout today's webinar. You can also use the chat box facility and there's the option to post anonymously if you prefer. You'll also see a few polls pop up and these are open to everyone. Finally, we'd love to get to know our live audience a little bit better. So if you feel comfortable, please pop a comment in the chat letting us know how you're connected to follicular lymphoma, whether that's that you're a patient, a caregiver, family member or a healthcare professional. And let us know where in the world you're joining us from. And please also participate in the polls if you can. We really value your voice and your presence here today. So without further ado, let's get started and I'll hand you over to Mitch. Thank you.
Thank you, Julie. It's a pleasure to be here, and thank you, all of the attendees. Hopefully we get the chat going in a little bit, and that's also a place where you can put some questions in that we'll try to address as we go forward, and perhaps a few others towards the end. So this is one of a series, and we have generally asked our audience what topics they want to hear, and this is one that's come up as a popular one because the disease is so heterogeneous and people have so many different journeys. The choice of treatment can be quite daunting. So we'll talk about some of the options and how one decides what treatments you might get. We're going to put up some polls here, as Julie mentioned, on who the audience is and what your knowledge base is going in. Don't be bashful. They should be coming up. And first one is, what's your current level of understanding of follicular lymphoma treatment options? And just from 0, which is I don't know anything, to 5, that I'm an expert. And somewhere in the middle, just rate that. There's no right or wrong answers. And we'll see that coming up. And hopefully we'll improve that level as we go forward. So please be answering those. And while we're doing those, the next one will be what treatments you've had or your partner or loved one has had. And then after that, we'll pop up one on, yep, there we go. This is a little complicated, so take a moment to read it. Again, no right or wrong answers, and you can have multiple. So some people have had by now 3 or 4 prior treatments. And some of the newer ones may or may not be available in your area. And then the last one will be the factors that matter to you. So while we're going through these, I'm going to take the opportunity to introduce and actually have our 2 panelists introduce themselves. I'm actually going to start with our patient representative, Bob. So Bob, can you tell us who you are and why you're here? And we'll hear more from you in a bit.
Hi, everyone. My name is Bob McEachran. Thanks very much for having me here. I was diagnosed in January 2008 at age 40 with stage 3, grade 1 and 2 follicular lymphoma. I was able to watch and wait for 2 years. And then I had 6 rounds of rituximab, and I haven't needed any treatment since then. I do a lot of work as a cancer advocate representing follicular lymphoma patients in lots of different ways.
Thank you. And yeah, we appreciate all that work you're doing. And our expert panelists today, I have the pleasure to introduce Professor Andrew Davies, and I'll let him introduce himself.
Hi, everyone. My name's Andy Davis. I am Professor of Hematological Oncology, basically blood cancers, at the University of Southampton in the UK, and I'm a lymphoma physician. I'm really fortunate. I chair the lymphoma research group in the United Kingdom. We're a really strong group of very like-minded physicians who are exploring novel therapeutics and biomarkers in a range of different lymphomas. And I also run what we call the Experimental Cancer Medicine Centre here in Southampton. So that's us about exploring new treatments for a range of different types of cancers. So yeah, it's really great to be with you all, and I'm really looking forward to us having some good discussions now.
Great, thank you. I appreciate your time. Starting to see some work in the chat. So we're going to take a moment here to go over the poll. So level of understanding, it's as expected, it's pretty broad. A lot of people feel pretty comfortable, 3s and 4s, a couple of 5s, that's good. And you know, some people who really don't know much about it, and of course that's self-assessment. So we'll see how we do. The second poll, treatments. So interesting, about a quarter of patients have not started treatments or under watch and wait. A third have gotten monoclonal antibody only, and a little more than a third have gotten chemotherapy. Most of those are with antibody, I presume. It is interesting how few people have gotten some of the newer treatments that we're going to talk about, lenalidomide, CAR-T, bispecific antibodies, only one person, and tazemetostat, which has been approved for several years for the follicular lymphoma. So that will influence a little bit of what we hear, and a few people have had some other things as expected. So when you're considering a treatment, again, people want something that's effective. They want, they're concerned about side effects and how it affects their quality of life, short term and also long term, which is one of the things we often think about when we talk about sequencing treatments and how you choose a treatment. Convenience, access, and cost seem to be less important, which is also interesting. We've had some previous work where convenience and travel time to the center actually played a larger part. So we can discuss some of those. So with all of that intro out of the way, I'd like to turn to Andy and say, have him talk about a little bit about what, oh, I'm sorry, I do want to just make one clarification. You know, we're going to talk about a lot of things today. It's important to our patients that they have the knowledge to talk to their physicians. We are not providing any personal medical information or medical advice. It's really information that allows you to work together with your healthcare team and address some of the uncertainty and challenges that this disease has. So we are not representing ourselves as providing any answers to your personal medical care at this point. So Andy, you know, one of the things that comes out is we have people here, you can see from global, UK, Canada, US, other Australia, depending on the time frame. And so some of these treatments are available in certain areas, not in others. I wonder if you just take us through a little bit about what treatments are currently available today, perhaps in the UK, what you might know of elsewhere, and how they're typically applied.
Mitch, thank you. And yeah, I think it's really important to say that, you know, there's a whole range of different treatments available for follicular lymphomas, and some of these may be available in your territory. They may be approved, they may be funded, or they may not be approved and they may not be funded. And so again, that's a kind of a discussion to have with your own physicians. But in follicular lymphoma, we have this really massive range of approaches to treatment, and that can range from a simple watch and wait approach that sort of Bob has started to talk about, all the way through the range of chemotherapies with antibody molecules, to treatments with small molecules, treatments with antibodies, what we call bispecific antibodies, which I'm going to come back to, CAR T-cell therapy, and even sometimes of transplantation, rarely for some individuals. So we have this sort of great range in types of treatment and perhaps the intensity of treatment. And there's a lot of factors that we need to think about when we're making a decision with the patient about what the kind of the optimal therapeutic approach is going to be. So I think we can divide it up in sort of to look at the first treatment that patients may need. And many patients may initially, when they first present, not require any treatment at all. And that's because the follicular lymphoma is not causing any symptoms, and it's what we call a low burden. So the amount of lymphoma, the size of the lymph nodes, is not particularly big. And I think it's, for those patients, even in 2025, what we call watching and waiting and not giving any active treatment, is a really still an important modality. And we recognize if we follow that approach, that on average, patients will take 2.5 to 3 years till they require therapy. But remarkably, I think that about 20% of patients 10 years from having been diagnosed with low tumor burden follicular lymphoma may never have required any treatment. Now, there are some people who start to develop symptoms from their lymph node. They may get a large lymph node that causes some pressure, or their blood counts may not be so good, or they may have symptoms, constitutional symptoms sometimes from the lymphoma. And when that happens, we've kind of got a choice of giving patients antibodies on their own, and you might hear about people having rituximab or obinutuzumab, and these are antibodies that target a protein on the surface of the lymphoma cell, and they cause the death of the lymphoma cell by really engaging the body's own immune system. And we can deliver those, and actually we can deliver those quite safely, and they've got a pretty low toxicity. For patients who have got a bit more disease bulk and who are a bit more unwell from the follicular lymphoma, we generally use chemotherapy in combination with an antibody, because the antibody makes the chemotherapy work better. And you've probably heard about treatments such as CHOP chemotherapy. Those are just the initials of the chemotherapy drugs that are within there. Bendamustine chemotherapy, or sometimes CVP chemotherapy, and they're all associated with giving maybe 6 rounds of treatment every 3 to 4 weeks or so, and they are associated with high responses, and we recognize that those responses are typically very durable. Sometimes in the UK we don't do this, but in some territories I know that they do this. They can use a orally active immunomodulatory drug called lenalidomide, which can kind of boost the immune response to the lymphoma and cause a direct killing effect of the lymphoma, in combination with rituximab. That's the so-called R² regimen. And in a big study that was done a couple of years ago now, it was shown essentially to be near equivalent to the chemotherapy in terms of its effectiveness. Now, just because it's oral doesn't mean it doesn't have any side effects, and we need to think about that when we talk about using the R² regimen. And all of this is really tailored to the kind of individual patient. We tend to use R² in patients who've had a relapse of their lymphoma, and for patients with relapse disease, the options are, once again, giving more chemotherapy with antibody, sometimes giving patients some of the newer therapies. But sorry, the one modality that I forgot to mention is that we also use radiation in patients who may have just localized disease. When I mean localized, it may be just sort of 1 or 2 spots that are near to each other. So there is a kind of exciting range of new therapies beyond chemotherapy that is evolving, and we're working out how to use this in the treatment sort of programs of patients with follicular lymphoma. And they include small molecules like a drug called tazemetostat, which is a tablet which for some patients with a selected type of abnormality in their follicular lymphoma, particular mutation of a gene called EZH2, we can see good responses in some patients in multiply treated disease. We can also use antibodies that target both the surface of the lymphoma cell, but also bring T cells, which are like the master regulators of the immune system. They bring the two together, and the T cells get activated and they kill off the lymphoma cells. And these are just recently being approved now. You probably heard about things called epcoritamab and mosunetuzumab, for example. In some territories, a drug called rituximab has also been approved. So bispecific antibodies, of course, there's CAR T cell treatment. So CAR T cell treatment is when the T cells are taken from the patient, they are collected and they are manipulated outside the body. A gene is put inside them to react against the lymphoma cells, and then they're stimulated to grow, and we give them back to the patient after they've had a little bit of chemotherapy in order for the patient to be able to accept it. And I think we're very excited about the promise of CAR T cell therapy, but that comes with some unique toxicities. There's some new antibodies on the horizon. There's a new antibody that targets a different protein on the surface of the follicular lymphoma cell called tafasitamab. And so we have this sort of whole range of treatments. There's also other orally active drugs called from this class called BTK inhibitors that we use in other types of lymphoma. And the story is evolving that actually they may be quite useful in patients with follicular lymphoma. So there's lots of different drugs, or there's lots of different therapeutic approaches for patients. It's like figuring out, really importantly, what's the right one to use at the right stage of the disease that's right for the patient and really achieves the goals that you want as a patient in terms of the effectiveness and the toxicity and all those other things that we think about.
So I got to tell you that's an incredible amount of stuff you covered brilliantly, I must say, having tried to do that before. That really, and it does highlight the number of options that we have. And I think we'll come back in a little bit some more of those in more detail, as you mentioned. We can see in the chat already people have had many of those: bendamustine, rituximab, R-CHOP, antibody alone, some radiation. So there is no one right answer for everyone, and that's a key lesson. Let me switch over, come over to Bob here for a little bit. You mentioned a little bit about what happened. I'd like to delve into a little bit because you've had a couple of decision points. The first diagnosis: should I get treated or not? When I do need treatment, which one? And now, how do you feel having year after year been sitting there not knowing what's going to happen? So I'm just going to give you free rein there to cover a few of those.
Okay, gosh, where to begin? It's been quite the journey. I'll start just with how I was diagnosed, because I think maybe some of the folks who responded to the poll might have a similar experience, given that a whole bunch of them haven't had treatment yet. My diagnosis was a complete shock to me. I was the healthiest I had ever been. I had just turned 40 years old. A friend of mine decided for his 40th birthday to get a tattoo. I didn't want to go in that direction. I decided I was going to train to run a triathlon. And I discovered quickly that I'm a horrible swimmer, but I'm a decent runner. So I was running 5K races and 10K races. And as I said, I was in the best shape of my life. And then the summer before I was diagnosed, I got some bronchitis and I had a hard time shaking it. It eventually turned to pneumonia. Got rid of that. But the bronchitis came back and the pulmonologist said, let's do a CT scan just to be safe. Just had a little swollen lymph node in my chest. He said, 5% chance it's cancer. A few months later, of course, it was a little more than 5%. And I got the follicular lymphoma diagnosis. And as I said, complete shock. I was asymptomatic other than that. And for that first month or so after the diagnosis, it was a familiar story, I'm sure, to people who are listening. A lot of blood tests, a couple of scans, bone marrow biopsy, just trying to figure out where we were. And all this time, I am doing what most patients do, Googling to try to figure out on my own what's happening. And I remember Googling something and Googling follicular lymphoma and seeing something about watching and waiting. that there are patients who don't need treatment right away or who choose not to get treated right away. And that sounded absolutely ridiculous to me. Why would anybody possibly choose not to be treated when they had cancer? So I just hit the back button and went back to my Google search. And then, of course, a couple of weeks later, after we kind of had a bigger picture of where I was with the disease, my oncologist suggested watching and waiting. And I said to him, that's ridiculous. Why wouldn't I get treated? But he explained the whole idea behind it. I was 40 years old. He's looking at a much bigger picture than I am. He's looking at hopefully my living with this disease for decades. And so if we can hold off starting treatment and hold off with the side effects that will inevitably come with any treatment, then maybe that's what we should do. So after that discussion with him, that's what we chose to do, to watch and wait and not begin active treatment right away. That was a hard decision. I remember my wife, who was a planner. I was diagnosed in January. She had things planned out. Chemo, we're going to do chemo. We'll be done by chemo. I'll be feeling better by the next Christmas, and we'll have a normal Christmas, and life will be back to normal. And of course, life has never gotten back to that kind of normal for us. And over time, I've kind of learned to live with that uncertainty, that initial uncertainty that came with watching and waiting, and then post-treatment, 15 years of kind of living with that uncertainty as well.
Andy, a lot to unpack there. I wonder about your experience. My experience with people have Bob said, "What are you, crazy? I got stage 4 lymphoma, and you're not going to treat me." And then after 6 months or so, when they realize they're fine, then when they do need treatment, they've gone the other way and they go, "Oh, wait, I've been doing great. Why do you want to treat me?" So, any input on that one? And
yeah, I think when you first meet somebody who's got low sort of burden follicular lymphoma without much in the way of symptoms, there's a high expectation, and often they've come from one of the kind of specialists who said, "Oh, you're going to go and see Andy, and he's going to give you some chemotherapy and all the rest of it, as well as what the patient's read as well." And so there's quite a lot to do in those conversations when we talk about the watching and waiting approach. And I believe, here it's still 2025, that watching and waiting is really an important and the best way forward for patients. Because what your oncologist absolutely said the right thing, Bob. We're thinking about a strategy for the long term, and we're not just worried about what's going to happen immediately and making something smaller in your chest that you didn't even know about. Actually, what we want to do is think about the whole strategy for the kind of a longevity of this disease. And I really think it's in the conversation, and I think it's really important that you have a good, well-paced and perhaps sequential conversation with your oncologist who can really explain about watching and waiting. And I always say to patients, we're going to keep you under our wing. We're not going to say come back when things are not you're not very well. We're going to be looking out for the signs of the disease changing and how you might be changing. So and we're going to support you through this journey. And I sometimes hear people say, well, watching and waiting is watching and worrying. It need not be, okay? It actually, if patients really understand the rationale for doing this and the long strategy that you're playing, I think that worry can be eased off. Now, we did some research in the UK with some other countries where we looked at giving patients who were, in your situation, Bob, but giving those patients rituximab treatment just straight off, even when they didn't have anything growing or any symptoms. And we found that the time to need more definitive treatment, maybe start chemotherapy, was pushed out. But actually there was a kind of an offset against that, of course, because you give patients rituximab and then there's a risk that the patients can get infections because rituximab is associated with a risk of infections. And actually it didn't make anybody live any longer as a result of doing it early. So I'm a great believer in saying, look, let's reserve these treatments until there's a very good reason. And then we can talk about the choices, whether, at that stage we give rituximab or we give chemotherapy or whatever we decide to give at that stage. Now, there's a kind of constant challenge in the research community to say, look, should we try and move away from this watch and wait approach? But I think it's still really robust, and we should continue to do this for our patients.
Yeah, there are, again, studies as the one you did with rituximab now looking at bispecific antibodies in this. And so it's reasonable to do clinical trials to ask the question, but we're not there yet. Bob, so when you did need treatment, did you sort of go and say, I don't feel right, I think something's going on, or was this just a incidental, it got bigger, we should start treatment? How did you feel? And then what went into the decision on Rituxan versus with chemo or not?
As Andy said, I was not out on my own. I was still going to see my oncologist every 3 months at that point. So I was having regular blood work. I wasn't having scans, but a 3-month checkup with a physical exam and blood work. So we were on top of things. Most of the activity for my disease from that initial scan was in my groin on the left side. It was in about 4 other places, but that's where it was most active. And after about 2 years of watching and waiting, I saw that my leg was swelling a little bit, and then it started to swell pretty rapidly. So, of course, I made an appointment with the oncologist outside of my regular appointments, and he looked and pretty quickly said, yeah, I think it's time. All of that time, over 2 years, we had been talking about possible treatments. It wasn't something that suddenly I needed to prepare myself for. I kind of had some idea of what it might be. My doctor's philosophy, which I really was pleased with, was do no harm. Again, he's looking at that big picture, knowing that there's a possibility that I'm going to need a whole sequence of treatments over hopefully decades. So he wanted to try as unaggressive approach as possible. That's what the philosophy behind watching and waiting was. So we had decided the first attempt we would make would be straight rituximab, and see how that went. And if that didn't get a response pretty quickly, then we would move to something else. And we had decided on CVP, which 17 years ago, I don't think it's quite as popular a treatment anymore, but it's related to CHOP minus one of the initials. So we had a plan. And again, that was not a plan that we came up with on that day. It was something we had been talking about and sort of looking at different scenarios. So that's what we tried. The rituximab, I had a very good response immediately. We had planned on 4 rounds of rituximab, and it worked very well for me. And he decided, since it was working, let's keep going with it. I had an allergic reaction the first time around, which is fairly common. But otherwise, they had tolerated it well, so we extended it to 6 rounds just to see how things were going. And it was very successful. As I said, I haven't needed treatment since then.
So we could spend probably an hour on any one of these decision points, but I see there's a number of people in the chat who have mentioned maintenance with rituximab or MabThera, and so was that discussed? And then I'll Bob, and then I'll ask Andy for his thoughts on, tell us, educate us on maintenance issues.
It was discussed because I brought it up. At this point, I was very active online with what I thought was a really, really great online support group. There was really only one around at that point. There are so many more now. So I had lots of experienced patients there who had told me about their experiences, and they gave me kind of the questions to ask. So I did bring up maintenance with my oncologist, and he said there was at that point more evidence that rituximab maintenance worked well following traditional chemotherapy, less evidence that it worked well following just straight rituximab. And that if the rituximab was working on its own, the risk of infection with so much more rituximab over a couple of years probably wasn't worth the effectiveness that might come from it. So we did talk about it because I brought it up because I had heard about it from other patients, and ultimately we went with that decision to not do maintenance.
Yeah, I think that's a great example of how the importance of you having knowledge, being able to discuss with your healthcare provider the pros and cons and what works for you at a certain time. And do you want to educate us a little bit on maintenance, pro, con, et cetera?
Yeah, I mean, this is, as you say, this is a really important one for this shared decision making. So there's some big trial data for patients who have had chemotherapy with rituximab, and for those patients who get a good quality response, giving maintenance rituximab, so giving it a infusion of rituximab every 8 or sometimes every 12 weeks for a period of 2 years or so after completion of the chemotherapy. And that has been associated with delaying the time to recurrence of the follicular lymphoma. It's not been associated with any improvement in survival. So people don't live longer, as far as we know, as a result of having maintenance rituximab. And we followed that study up for over 10 years, and it hasn't shown any benefit in terms of living longer. So the pros are, it may well be that it keeps the follicular lymphoma away for a little bit longer, but it probably doesn't affect things down the line. And that might be an important goal, for an individual. The other thing, the negative side of it, is that actually it keeps you in a patient mode when you're in remission. So you're still keen to go to the hospital every 2 months, every 3 months to have an infusion, or now you can have it as a subcutaneous injection. And the key thing that I worry about maintenance is it considerably increases your risk of infection, because not only is it keeping the lymphoma cells suppressed, but it's also keeping your normal healthy B cells, which is a type of infection fighting cell, keeping those suppressed. So we absolutely have no doubt that patients who are having maintenance rituximab are at increased risk of infection. And I particularly am worried about maintenance rituximab in patients who during the induction chemotherapy have had a difficult time. Now, as Bob says, the data after having had just single agent rituximab of maintenance is perhaps less strong, but there is some good data there. But it was a really interesting study that was conducted in people who got a remission after rituximab, and half of the patients had maintenance, so they were regularly coming back for infusions of rituximab, and the other half of patients, they were just given rituximab if the lymphoma started to cause problems again. And actually the outcomes were identical. And actually the patients where you saved the rituximab in case the lymphoma came back actually ended up having much less infusions than those patients who were having the regular treatment. So this is one for having, again, a nuanced discussion with your physician. You'll find that there are some territories that are more keen, and there are some territories, particularly in the US, where there perhaps is less a sort of enthusiasm for it. I think I worry about it, particularly in the era of COVID and the vulnerability of COVID, because if it keeps your immune system suppressed, then it does put people at greater risk of more severe COVID type infections, even in the era of antiviral therapies and vaccines. So there's certainly a role for some individuals, but again, it's one to talk about what's important for you to your physician.
Yeah, there's a comment in the chat from someone who did have COVID while on rituximab maintenance. I think many of my colleagues here in the US, we did sort of change our practice from more commonly using rituximab maintenance to much less commonly in the COVID era for that concern.
Absolutely. And I think that hasn't kind of resurged quite so much. The usage, we're not back to pre-COVID levels because I think we're all really concerned about it.
Yeah, I agree. And as you point out, there's no perceived benefit in overall survival, and so the do no harm part is is key, and so it's probably on the balance fewer of us are using it, but not to say it shouldn't be done. It shouldn't be. So that's good. There's another comment here. Someone is going to go on an upfront trial with a bispecific antibody with rituximab, but a bispecific antibody. So what are your thoughts, Andy, on where bispecifics fit? There's another person saying, well, what, I'm having all these options, I think, after 2 rounds of 2 different lines of chemo. So where do bispecifics fit in your idea now and maybe a couple years from now?
Yeah, I mean, I think this is a rapidly moving field, and we're beginning to understand better where we might want to use bispecific antibodies. So as I explained previously, these are antibodies that kind of latch together your healthy immune T cells and the bad B cells, and put them together and cause the healthy cells to kind of kill off the lymphoma cells. And there is a number of challenges around bispecifics, and there's particularly something called cytokine release syndrome, which is when you can get a fever, or you can get some problems with blood pressure, or when you immediately have this in the sort of hours after the first couple of infusions. So when we start with bispecifics, we start with a really small dose, and we build these up over the first couple of weeks. But actually then you can have the treatment as an outpatient, and it's given every 3 weeks. And I think in patients who've had maybe at least 2 prior lines of therapy, and we've looked at bispecifics where the main license is sitting at the moment, we actually see really high response rates, and we see sort of 80% response rates. We see that benefit is durable, and actually they look to be really kind of safe to give to patients. So that's great. And in that, what we call the 3rd line space, we've seen a great amount of efficacy, and we've got approvals and funding, etc. Not everywhere, but in very many territories. So the question is, if you've got a drug that works well when you've had a number of lines of treatment, what about trying to use that earlier in the disease course? Because earlier in the disease course, you might get a better response, and you might get a response that lasts longer. And then the question about using bispecifics, perhaps in combination with other drugs, including this drug lenalidomide that I mentioned at the beginning. So there's a lot of excitement about using these earlier in the disease course, and there's now studies going on actually asking the question, should we really, because they're so good in the 3rd line setting, do you think we should be using these in the 1st line setting, the first treatment that people are having, and comparing a bispecific with perhaps more traditional approaches such as chemotherapy with rituximab? So and we don't know, and that's why we're doing the trials, to find out which one's better. And when we do a trial, of course, we'll learn about which one's better in terms of effectiveness, but we'll also learn about the different toxicities or the different side effects that these may bring. And so again, these are things that are really important to factor in, both the effectiveness, but also the toxicity, and perhaps try and identify which kind of patients they work best in. So I have no doubt that that we'll see rapid evolution in the way we sequence these treatments, and so something that we're using a bit later down the line, I suspect we probably will be using earlier in the disease course in years to come. But we've got to prove it works first.
Yeah, I think the key is that clinical trials, you really want to know, it makes sense, but doesn't mean that it is a benefit. And they are immunosuppressive, and they do lower your antibody levels, et cetera. So we think in the setting of a clinical trial, it's excellent, but not quite ready to give to everyone instead of chemo yet. Bob, have you had discussions about what if this comes back? What would be next? You were talking about CVP or bendamustine back then. Have you started to talk about bispecifics and other new treatments?
We have. I still see my oncologist every 6 months. He keeps saying we can make it a year, and I say I think 6 months is good, just for my own peace of mind. And pretty much every visit I ask, what's next? Just so we have a plan. We have a couple of plans. If it continues to take a fairly indolent course, still remains not too aggressive, we may try rituximab again, since it worked. We have talked about bispecifics and some of the clinical trials that are going on at the hospital that I go to, and some of those possibilities. I do keep up this conversation with my oncologist. This is a research center that I go to see him, and he teaches at a medical school. So I try to ask him when I can, what's exciting you about lymphoma these days? And he gets very excited, and that's always fun to talk to somebody about the exciting things, and it gets me excited about the future and not just for myself, but for all of us. What there is to be hopeful about. There is lots to be hopeful about. But I do keep up that conversation. I do try to stay informed myself so we can have this conversation and I can ask the right questions. And I can be prepared. I don't want to be unprepared.
So
Yeah,
Bob, I get asked that question a lot. What we're going to do next, and I'm always a bit elusive when we have that question. We talk about what's available and all the exciting things that happen, but I always say to patients, we'll decide that when we get to that point, because we can have some idea about what we might like to use, but actually the field is evolving so quickly with all these novel therapeutics that actually it may look different a couple of years down the line as what we think might be the best next. The data may have changed, we may have a greater insight and all the rest of it, and we may have different clinical trials and all sorts of things. So I kind of say, well, this is perhaps this is what we've got available. We'll look at the situation that you're in and how your disease is behaving at that time point, but actually we'll reserve our decision till we really need to.
Yeah, I think that's exactly correct. But it's exciting. I think the exciting thing is you have all these options. When I think about, Bob's been at this for a long time, and many of the things we're talking about right now didn't exist, even on paper, no less in clinical trials or approval. And let me ask you, Bob, something else. I mean, you were diagnosed, you mentioned at about 40, you're not 40 anymore. Do you think your decision-making process is different now? Work, family, how do those things factor into what you might decide for a treatment?
Things are certainly different from when I was first diagnosed. My kids were 6, 8, and 10 back then, and now they're all grown. So that's one less thing to worry about. I think I made the right decision with the rituximab. Um, Certainly, thinking about issues like how effective a treatment is, that's important, but also what kind of quality of life it's going to bring. I think I would still opt for something that helps me maintain that quality of life. I don't think I need a real long remission. I'm so used to living with this now that if I had something that let me continue to do the things that I want to do. My wife and I are traveling now and we're volunteering and I'm still working and I'd like to maintain that kind of lifestyle. So I don't want a treatment that's so aggressive that it's going to cause me physical issues. I'd be willing to sacrifice some time until the next treatment in order to maintain the kind of lifestyle that I'm used to living now.
And I think that's really important that those are the things that you articulate with your physician. And I think that's a real key message for everybody listening. Let them know what your goals are. The physician will probably have some goals, other goals as well. And you need to talk about those so that you can tailor the treatment and the sequence of treatment to absolutely what's right for you and what's right for your life.
So yeah, I think again the message is that we have lots of options and they have to be personalized to you and what's happened to you. Obviously, if you've had this long after rituximab, why wouldn't you go back to that again and save the fancier stuff for later? There is a question that we sometimes don't think about. Two people have asked in the chat about using a treatment again. And rituximab, the nice thing is you can use it as many times as you want. But two people have said they've had a decent, durable response to bendamustine rituximab. Why wouldn't they just do that again? And Andy, what are your thoughts on that? It's certainly something we would have done 10 years ago when we didn't have other options. What are your thoughts on that?
Yeah, Mitch, that's exactly what I was going to say. It wasn't too long ago that, chemotherapy was all we had, and we recognized that we would give chemotherapy and it would work, and we might get a long remission, and then we might give it again in some sort of similar or identical form, and perhaps less people would respond to it, and the benefit might be a bit less, and we would do this kind of in a successive way. Actually, I think we're smarter now, and I think we recognize that with chemotherapy, we recognize that your bone marrow can get tired of chemotherapy, and that might influence the effectiveness of some of these other treatments further down the line. So I think that because we have now got a selection of them, going back to something that you potentially had before is perhaps not optimal, and I think we can try and find something that's perhaps novel. We often give chemotherapy first line, and then we give chemotherapy again second line, but for some people we might second line give R squared and then give some of the other therapies further down the line. But I think the days of simply we used to just repeat chlorambucil, which was a tablet. We used to give it time and time again, but I think we've got smarter answers to that, and because people eventually become resistant to it.
There's another related question. Someone here has had RCVP and then another combination of two chemo regimens. Would that, I think, would fall under your same idea? If you're resistant to one chemo, you're probably resistant to chemo. We're looking for non-chemo. Some of these newer non-chemo approaches would make sense, bispecific, CAR T, et cetera.
Yeah. And the lenalidomide also, of course, is a non-chemotherapy approach. Yeah.
We shouldn't forget that one. Yeah. So, we're getting on here. I just want to come back to Bob. I know you mentioned you do blog writing and things. You share your story. You had patient contacts, group support, which you find very useful. Any comments on, how you stay informed in terms of what's out there, and any advice for people, listening, the good sites that you find useful?
There are a lot of great sites. There are a lot of not so great sites. It's the internet, naturally. There's going to be a lot of good stuff and a lot of not good stuff. I keep informed by looking at reputable sites. The Follicular Lymphoma Foundation is an excellent one. Lots of very good information there. And generally, organizations like that rely on medical experts to provide information. Those are the ones I try to stick to. Online groups, sometimes they can be a mixed bag. I got lucky to get a really good science-based one when I first started out. There are some that aren't so science-based. And you have to be careful about those. The Facebook group Living with Follicular Lymphoma, I think, is generally very good. Lots of good informed patients. I think they provide good information. All of the information about the disease they provide is probably best checked with your oncologist. If something seems too good to be true, it probably isn't true. But the online support groups like that Facebook group, I think, are at their best when they allow patients to see that they're not alone. When you ask a question or you read a comment and realize that somebody else is feeling something that you didn't think anybody else was feeling, that's something that you were feeling, and now you realize you're not the only one. That's when it helps to feel like you're not alone. Often a good source of medical information, just in the sense that it provides you with something to talk to your doctor about. But certainly your doctor is the best person to talk to about medical issues, and not some guy with a blog.
And
Go
ahead. Sorry.
I was just going to say, just many centers will also have lymphoma nurse specialists as well, who really can provide some sort of expert psychosocial support as well. And many people find real value in having good conversations with their lymphoma nurse specialists.
Yeah, I'd echo that. Nurses are very good, and they have a little more time than the doctors often, and they really know their stuff,
Yeah.
the day-to-day things. We do have on the FLF, we've had our previous webinars, we did have one on psychosocial support. We have had others on treatment. So if any of you, we haven't answered your exact question, you might go back to some of those webinars, which cover some of these. Andy, there's a question here about RSV vaccines, but I just want to, in general, your comments on vaccines, yes, no, and the timing. I know, they may not be as effective, but they get some effect. Is it important to do it before you start treatment? How do you approach those? I mean, COVID vaccines, all these other issues.
Yeah, I mean, I think, if you can have a vaccine before you're going to start, rituximab or chemotherapy with rituximab, I think you should try and get your vaccines done beforehand. I often feel like I'm on repeat because every time I see a patient that we always talk about vaccinations. And even if you're post chemotherapy or you're on maintenance treatment, you may not mount quite the same response to a vaccine like a flu vaccine or a COVID vaccine, etc., as somebody who has not had treatment. Actually, you'll probably get some benefit from it. So I'm always pushing, making sure everybody gets their annual flu vaccination, and you have your COVID and you follow the COVID booster schedule. And I think that's really important that in your own territory there'll be a release of boosters for COVID in different ways. But actually, your primary care physicians or your oncologist or your hematologist will have a mechanism of making sure that you're alert to your need to have vaccinations. So I'm really absolutely in favor of making sure everyone stays up to date with their vaccinations.
Right, and just to clarify, so you say you may not get the maximum benefit, but you'll get some.
You'll get
there's
some.
no evidence. There's no evidence that you could get harmed by these
That's
vaccines.
exactly right. That's absolutely right. And I think what's important is that although you may have had a treatment that may have affected your B cells, which are the cells that go wrong in follicular lymphoma, that's just one part of your immune system. And that we know that people with follicular lymphoma who may not have very many B cells because the rituximab has reduced them, actually we know that they've got good T cells that are active against some of the, like COVID, etc. So please, yeah, definitely go for your vaccinations.
Great, thank you. I'm looking through the questions in the chat. We've answered many of them in the descriptions, as we've tried to cover about some of your questions. Hopefully, we have answered them. All right. One question's come up here is about, a little bit about follow-up, and I'm getting a sense that maybe at least a couple people in the UK have been told they're followed more by their GP than by their oncologist, and don't worry about it. So, Bob's being seen by his oncologist twice a year. And what are your thoughts on follow-up on someone who's not actively in treatment?
Yeah, I think again, follow-up is kind of tailored to how the disease is behaving. And so for somebody who's been on watch and wait for a long time, for a number of years, and they're doing well, then we might, reduce the frequency of follow-up to say 6 monthly or so, as long as patients have a clear mechanism to be able to access you. So they absolutely know how to get hold of you or to get hold of your nurse specialist or your team. And the door is always open. So you can ring up and say, look, I've got something that I'm worried about. And I'll say, right, well, we'll see you this week, etc. So I think having the door open. So for patients who, who've had treatment, they've successfully completed treatment, then I keep a kind of a quite close rein on them in the first couple of years after treatment, because what I want to do is get a feel for how much benefit they've had from the chemotherapy or for whatever treatment it is. And we know that a small percentage of patients may relapse early after follicular lymphoma. I want to be able to, after chemotherapy, I want to pick those patients with follicular lymphoma up early because they might need to have kind of more intensified approaches. So particularly after chemotherapy in the first couple of years, I may see people on a 3 monthly basis or so. But then as we go past the kind of the the risk window of the first 2 years, then I'm going to reduce the follow-up. But again, I think what's really important is that you have access and that you don't have to go back to primary care, or you can't, I know that every system is different in different countries, but absolutely you can see your hemato-oncologist whenever you're worried about it. And that's the most important thing. And we equip patients to be able to do that.
Great, thanks. So as we just have a few minutes left, I do want to pull back up on that now that we're coming to the end, how you feel about your understanding of follicular lymphoma treatment options are. We won't repeat the other ones. And of course, as we said, there's no harm to vaccine. Someone has commented about their awful reaction to a COVID vaccine, interesting timing from rituximab, et cetera. And yeah, I mean, there are, all vaccines have some potential toxicity, whether it was related to your FL or the fact that you were going to have a reaction anyway, I think is an unknown. And while we're putting that poll up, Andy, there's a specific question for you. Can you use bispecific treatment as a second-line treatment in the UK as part of a trial?
So as part of a trial, yes, but outside of a clinical trial, unfortunately, it's not funded. And in fact, in other settings, bispecifics are still not funded in the UK, although they are approved. So just in the UK at the moment, the access point is through clinical trials. I think that NICE, who is our funder, the National Institute of Health and Care Excellence, had a look at the economics and struggled a little bit about it. I think we are somewhat out of step with other territories in the terms of the funding of bispecifics, and we hope that's going to be changing as we accumulate more data in the future.
I think that's really important. The bispecifics and CAR-T are still very new, and the data is being updated at almost every major meeting several times a year, and it's definitely coming. So as the data changes, I think the utility will change. So it looks like we've shifted the curve a little bit. Most people feel a bit more comfortable about their knowledge, so we're pleased by that. And I want to thank Bob for his personal reflections on that, and Andy for his superb descriptions. I can't imagine a more concise description of these broad things than he has provided, so I want to thank him for that. Also want to thank the sponsors, and there's a slide that'll be going up of our sponsors who to thank you for attending, and the people who have allowed us to do this. As I said, we do have previous webinars on our website that are available for viewing that cover some of these topics in more detail, and we will have some additional ones coming up. So keep your eye out for those. And Bob, any 60 seconds for a last comment or anything you would like to add that we haven't covered?
Not that we haven't covered, just that I think it's an exciting time to be a follicular lymphoma patient because there are so many great options for us, and it seems like so many more coming down the pike. So it's a good time to be a patient now.
Yeah. Andy, any last thoughts?
I mean, exactly. The landscape is changing. What I would say is make sure you tell your oncologist or your hematologist what's important to you. I think that's really important because there are so many factors that we need to think about when we choose the right treatment for you.
Great messages. Great messages. I echo those sentiments. For those of you online, there will be a questionnaire that pops up at the end. We would really appreciate your filling that out to give us your feedback. And also thoughts on topics for future webinars. We want to do these that really inform you. And so it really helps us to know what topics you want. And with that, and about 10 seconds to spare, I want to thank Andy and Bob. I want to thank my team at the FLF and all of you who are attending now and who will be looking at it online in the future. So thank you, everyone, and have a good morning, afternoon, or evening, wherever you are.
Thank you, and thanks for inviting us.
Great, thank you.